We need to make sure that nurses know that before and after medication administration, we should be assessing and flushing our lines. After we administer blood products, it's very important to pulsatile flush those lumens of the catheter. I saw a lot of nurses who just let the pump do the flushing after the blood product or in between the medications. And we know that that slow, continuous drip is not going to be enough to keep the debris out of that catheter and to really keep the lumen clear.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we're talking with MiKaela Olsen, Clinical Program Director in Oncology at the Johns Hopkins Hospital and the Johns Hopkins Health System in Baltimore, Maryland, about the harms of heparin flushes and the latest recommendations for flushing central venous catheters. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, MiKaela. So to start us off, we have in the past talked about central line catheters and the importance of using them and how so many of our oncology patients have them and use them for their treatment. So many of our listeners that we have, whether they're tenured and experienced oncology nurses who have worked with central line catheters for a long time, or they're new graduates or nurses who are new to oncology, this information is going to be so important and so helpful to them. So can you talk to us a little bit about what the evidence previously said about flushes for central venous catheters, and we'll call those CVCs from now on, or other access devices?
I like to start by telling this story. So remember, for many years, I've been an oncology nurse for 30 years, and much of my career before and into the 90s, we called the peripheral IVs heparin locks because we would put heparin in those peripheral IVs so that they wouldn't clot off, or at least that's what we thought. And then large studies were done, and they discovered that it was not the heparin that was keeping the line open, but that just flushing that peripheral IV would keep it open. And we moved away from heparin in our peripheral IVs back in the 90s. And then in the early 2000s, we also discovered the same thing in our arterial lines and eliminated the use of heparin to keep open the arterial lines, instilling it into the bags that we used for arterial lines. Back in about 2016, 17, I was in my doctoral program, and I was looking for something that I could do as my quality project for my DNP. And I started really becoming interested in some articles and literature that I was reading about heparin usage in central lines. And what I realized was that there have been, for many years, evidence that heparin may not be superior to saline for the use of central lines, but many of those studies were single studies, and they really didn't mention flushing technique or any other details. Sometimes there was conflicting evidence. And so during the course of my studies, I found numerous very well controlled studies, and then even higher levels of evidence with meta-analysis and systematic reviews that were done showing that heparin was not superior to saline. Some of those studies were in oncology patients. At the time, I found at least 15 randomized controlled trials, including 3 systematic reviews and 2 meta-analysis that had been done from years 2014 and beyond. And interestingly, there was another one just published a couple weeks ago that I actually haven't read yet completely, except the final results, but also with the same evidence. using this evidence, and that's what you do in a DMP program, you use existing evidence to move into clinical practice. I wanted to understand what were the barriers if we had such good evidence and we were using a medication instead of just plain saline, and a medication that can be harmful, which we'll talk about in a little bit. I really wanted to understand, why wasn't it working in clinical practice, or why weren't people running to do this, because it seemed like such a great idea. And so I started to study the barriers, and I realized at that time that it was really not what was being flushed in that catheter as much as it was the technique of our flush and the frequency of our flush to keep our catheters from being occluded. So definitely there's lots of evidence, and we have evidence published in all kinds of central line catheters, and we have evidence in inpatient settings, in the ambulatory settings, in oncology clinics, and some of that evidence has been published in our own ONS publications. And so what I like to focus on when I talk about this is the way that you can eliminate heparin, and that is by really focusing on education and teaching of patients and nurses and other staff that access central lines about how to do that. There's really an art to how we keep our catheters from being occluded and how we flush them.
It's good to know that this evidence is emerging and that we are having more evidence to support this change. So, how has this changed nursing guidelines in practice then?
Well, I think that we're still catching up, and as our guidelines are sort of up for review again and we re-review the literature, I think we will see this incorporated more and more into our guidelines. There's a lot of new emerging evidence about the frequency of port flushes and how we don't need to flush them as frequently. During my doctoral studies, I actually was able to eliminate heparin from our entire cancer center, but I did that in stages so that I could properly teach the patients and the staff along the way. And then we moved that now to our entire organization and put that into our policies and procedures based on the fact that it was working for us. But many places will wait on making these changes until these nursing guidelines get updated. And one of the barriers right now, I think, is that a lot of the manufacturer guidelines are old, and they still recommend in their catheter guidelines to use heparin because they aren't up to date either. So I've been reaching out to some of those manufacturers to say, hey, here's the new evidence. Please have your company review this, and please look at changing your guidelines, because unfortunately, if a company makes a certain catheter and then in the IFU, the instructions for use, it says to use heparin, people are going to have a problem not doing that. We need to get all of these things changed with the current evidence, and that will take time. But I can assure you that if you look at the literature and the references that support this and talk to organizations that have made this change, that it can be done successfully. But again, I'll keep focusing on, it's about the frequency of flush and the way we flush that keeps these catheters from being occluded.
Excellent. Can you talk a little bit about what the potential harms and complications are associated with heparin flushes, since we're talking about the two different types of flushes now?
Sure. The nice thing about saline is it's very benign and doesn't have any risk of harm for the patient. They're small doses, so we're not worried about sodium or anything. The risk of heparin is actually quite extensive. So, for instance, we know that heparin can cause heparin-induced thrombocytopenia, or HIT. Unfortunately, you don't always know that your patient is experiencing that. But I've had many, many patients over the years where all of a sudden their platelet count was low and no one knew why. They weren't getting anything that we thought of that would be immunosuppressing their platelets, and we couldn't figure it out. And then we did testing for HIT and found out that it was the heparin flushes that were causing that. So the incidence is low, but it is something to be concerned about in our patients that already have a risk of bleeding and other complications from low platelets. In some of our catheters, we have traditionally put large doses of heparin in them. So, for instance, in our transplant program, for our pheresis catheters, we were putting 1 to 1,000 2 cc's in each lumen, and the patients were flushing at one point twice a day. And then when the patient was doing it themselves, they were not wasting in the home. So there's potential for causing bleeding or other bleeding coagulation problems from the excessive heparin that we put into these catheters. There's a risk of anaphylaxis. And it was interesting and timely that when I was getting ready to implement my project, we actually had 3 different situations where a patient anaphylaxed from a heparin flush. So again, although rare, it happens, and it can be very devastating for the patient and very scary for the staff. The other thing that can happen with heparin exposure is something called biofilm formation. Biofilm, heparin mimics this extracellular DNA in binding to cell surface that localizes protein and causes this film inside the catheter. And that substance called biofilm can actually promote the growth of bacteria and harbor bacteria. And Staphylococcus aureus is one of those organisms that is associated with biofilm formation. So what we worry about is that heparin leads to biofilm formation, and then that can lead to an increased risk of central line infection. The other thing I like to mention is that heparin is made from porcine products or pig products, and some patients have religious or other beliefs against receiving any product like that, but it's not something we frequently tell our patients about or even mention to them. One of the things that I was able to look at is, are nurses actually barcoding the heparin before they give it? Do we have orders for the heparin that we're giving? Or is it being regulated in that way? And a lot of times, because it's a lot of work to do that, we have non-compliance with that. That could lead to harm if we don't know somebody has an allergy because we're not ordering it or barcoding it, and then we accidentally give it to a patient. If heparin's locked in the catheter, then the other thing we see an increase of is skewed laboratory results. If somebody doesn't properly waste before they draw the specimen, then you can have problems with inaccurate laboratory results. Those are most of the risks of heparin exposure that I can think of.
Excellent. Thank you. So you've mentioned a few times saline. Is that the only other solution or the only solution that can be used instead of heparin?
Normal saline is the most benign solution that can be used in catheters. There are studies showing benefit in some patient populations, and I know some places have protocols using an antibiotic lock solution or a sodium citrate lock solution. But in general, the most common type of flush solution for central lines as heparin begins to move out of favor is normal saline.
Let's move on and talk about the how. You've mentioned a few times that it's not only the solution that's being used, but it's actually how the flushing is being done. Can you explain to us what pulsatile flushing is?
So we know that using a push pause pulsatile, or I call it sometimes turbulent flush, has been shown to promote the clearance of the catheter lumen and prevent occlusion. That means that according to the Infusion Nursing Society guidelines, which is one, or standards, it is a standard, which is one of the standards that we look at around vascular access device, in addition to the ONS standards, we are instructed to do a stop and start every milliliter of flush. So if you're flushing an adult with a 10 cc syringe, you're going to stop and start every cc, which is 10 times. That is really important because every time you stop and start, you cause turbulence in that catheter, which helps cause this whooshing or vortex movement in the catheter to really clean it out. there actually are some really cool studies. If you are a science geek and like to look at things like that, there are some pretty cool studies that look at the continuous infusion of a flush, a slow continuous push, or a pulsatile or turbulent flush. And those studies actually showed that you clear the catheter better with the pulsatile flush and you have less bacteria buildup in that catheter. So it's pretty clear to us now, not just that we made this up, but that there is evidence behind using pulsation. And that's something that surprisingly, if you go out and audit nurses, you will find that the majority of them don't do it correctly. So what I did was I did pre-flush observations. I just said, flush it like you normally do. And I snuck some scrubbing of the hub in there because that way I could do both things at the same time, which is kind of fun because also nurses don't always know the proper way to scrub the hub, making sure that they really clean that hub all around the lure and the top of the interluminal pathway. So I snuck both in together, but only about 8% of the nurses used the exact stop start every milliliter pulsatile flush. Some did partial pulsation. Some did just a pulsation at the beginning and then maybe at the end. Some did this very slow, continuous flush. So now with the evidence and knowing that a pulsatile flush is more effective, we really need to do that. We need to teach it to our patients. We need to say 10 times. Patients can watch us do that. We can count it easily even while we're talking to a patient. And we want to make sure that we do that pulsation every time. And that's going to keep our catheter from getting clogged up as much as possible. And I also will say there are always going to be a subset of patients that are going to have catheter occlusion related problems. That could be mechanical because of the way the catheter was placed. It could be host related because of their hypercoagulability. But most patients will respond to just a regular saline pulsatile flush. I just don't want anyone to think that we're going to go to this pulsatile flush and eliminate heparin and only use saline, and now we're never going to have to give a declotting agent like alteplase, because always there will be a need to declot catheters if they get built up and clogged up. But how we flush will hopefully minimize that.
Thank you for explaining that. I think your explanation is just so helpful to understanding kind of that how to and the importance of it. So what should oncology nurses keep in mind about the frequency of flushing?
Again, this is something that when you study it, you find that people, patients or nurses are not actually flushing enough. If the patient's at home and you're using saline, then the catheter is usually flushed on a daily basis with pulsation when not in use. If the patient's giving themselves antibiotics or other medications through their catheter, they need to be taught how to do the saline flush after each of the medications. An interesting thing when I was doing the quality improvement study is that patients would have the antibiotic balls and they would go to bed with it at night and it was sticky and they would not take it off until they woke up in the morning. And then we saw an increase of occlusions in that population. But then when we said to them, you really need to set an alarm and flush your catheter after and get your ball disconnected for infection reasons and for occlusion reasons, then we saw a reduction in that. So in the home setting, it's about teaching the patient. In the hospital setting, we need to make sure that nurses know that before and after medication administration, we should be assessing and flushing our lines. After we administer blood products, it's very important to pulsatile flush those lumens of the catheter. I saw a lot of nurses who had just decided they didn't want to wake the patient up during the night or bother the patient. So they just let the pump do the flushing after the blood product or in between the medications. And we know that that slow, continuous drip is not going to be enough to keep the debris out of that catheter and to really keep that catheter clear, the lumen clear. And then after we obtain a blood specimen, of course, when the device is not in use, if we notice any blood or debris in the tubing or the needleless connector, we need to flush it or change it out immediately. We can use a competency or skill validation checklist to do this flushing. And so that's really actually very helpful. So now in our vascular access training, we not only have how to do a dressing and how to declot and how to do all these things, but we also have a flush competency checklist so that nurses actually learn it the right way every time. And you can do something very simple as getting a large mason jar and then poking some holes in the top and putting a catheter inside and put some saline in there and show the nurses what happens to the fluid and the catheter when I just do this real slow continuous flush, but what happens and what does that turbulence look like when I really pulsatile flush it. I will say, make sure that you never force flush a catheter because we don't want to have a catheter damaged or a catheter embolized. So if you have a problem with being able to flush, you have to do troubleshooting.
We've talked a lot about what should be used to flush catheters and the process of how they should be flushed. So how is this changing oncology nursing practice for central lines?
I know that in my organization, it was a very, very well received change. Of course, at first, there are going to be nurses that are holding on to the old way of doing things, but it's about teaching new evidence and helping them understand the new evidence and then helping them understand the frequency of flush and the way to flush to prevent occlusions. I think that what the nurses were most excited about is, of course, reducing the patient risk from the exposure to heparin, but also it is really a time waster when you have to go and find heparin, different concentrations. You have to either initiate a therapy plan in your EMR or ensure you have provider orders. Providers don't always know what to order. And then you have to barcode the medication and administer the medication. And then you have to work with pharmacy and social work and case management to get prescriptions for the patient, for their heparin, for their flushes at home. And it's just a lot of work to do all this. And frankly, a lot of places have non-compliance with this because it is so much work. And when you go to a very focused pulsation type of flush and you teach nurses how to flush frequently and how to keep these lines clear and preventing occlusion as much as possible, then you focus on that part and then you don't have to do all that other work. Patients can actually obtain saline, some from their insurance company and through a local pharmacy, but you can also purchase sterile pre-filled saline syringes over the internet through specialty places or even Amazon. So it's much easier for our patients to be able to get this.
Those are really good points. And I think that for our listeners who maybe work in a location that, has not changed their process or their policy for flushing central lines, you've given them a lot of good information and recommendations on what they can take back and really kind of review their policies and then how they can already have the support or the evidence to help put that into place and help make the changes that need to be made in their facilities. So one of the things that you mentioned were the nursing guidelines, and ONS definitely has several resources and guidelines to support flushing practices. But can you tell us a little bit more about how would a nurse use those guidelines and resources in practice?
Well, I think that there are stakeholders involved in moving toward saline pulsatile flush and trying to eliminate heparin. And some of those stakeholders include providers, pharmacy, your apheresis center, your ambulatory areas, your vascular access teams. And so the good news about guidelines and standards is they will pull all that literature together for you in the references so that you can use these standards and guidelines to take back to maybe it's a small community practice and you work with a provider there that runs the practice and you need to show him the new evidence so that you can eliminate heparin in your clinic. Or maybe you're in a larger organization where you need to talk to pharmacy and the P&T committee, pharmacy and therapeutics committee and providers. So that's how I tend to use guidelines and standards. It can be very helpful. So we will definitely look forward to lots of new vascular access guidelines being updated, including the ONS guidelines.
As you've mentioned, whether nurses are using the guidelines, they're looking at the evidence and they have that evidence, but you mentioned early on the key factors of educating colleagues and the other staff on flushing. What are some of the key factors that nurses need to keep in mind when they are doing that education?
I think definitely things that I mentioned, like the technique, the frequency of flush. One thing I didn't mention that I think is a key factor in all of this, and that's probably another podcast separate from this, but the needleless connector that you use on your central device, central line, is really important in this whole equation because needleless connectors perform differently depending on the manufacturer. And it can also help promote the prevention of occlusion if you have the right needleless connector, the right technology, and it can be sort of complementary to your flushing. So I think for education, what I learned is nurses learn by understanding the evidence and understanding how to interpret the evidence, and then they learn by visualization. And so, as I said, using a model, a flush model that you can have them get their hands on and play with is really going to help them. It helps also for teaching patients as well.
Excellent. I love that idea that you gave about the mason jar because it's just such a visual for folks to, whether it's other nurses or patients. That's just a great teaching tool. So, MiKaela, we are coming to the end of our podcast again. I feel like these go by so quickly when you and I are talking because you are just so passionate about some of these topics, and just you talking about the research that you did to make those changes, first of all, in the oncology setting at your institution, and then, it moving to being an institution-wide policy, and just how impressive that is that kind of thing was done, that you implemented that. So I want to finish us up and have a couple questions to ask you. And the first one I have is, what are some common misconceptions about implementing saline versus heparin flushes?
Well, I think the main one is that heparin is more powerful than it actually really is. Heparin has a very short half-life. So the fact that someone believes that it could sit in that catheter and prevent occlusion for a patient that's only getting flushed once a week, or a port that's only being flushed once every 30 or 90 days is really not really appropriate thinking. And the other misconception is that without the heparin, we're going to have a really high increase in occlusions. And I will say that, again, that without the places that have had failures, it was most likely probably, of course, due to you're now using less volume and you're not pulsating when you flush. So if you eliminate heparin, again, focusing on the frequency of flush, the right amount of flush, which is in adults, as I said, 10 cc's, and then frequency and pulsation is really, really key. There's also a misconception out there that heparin can be instilled into a catheter to help with an occlusion, and that's absolutely not true. Heparin prevents the growth of new clots, but it will not dissolve an existing occlusion or clot or fibrin. So I used to see nurses putting large doses of heparin in catheters and letting it sit because they didn't want to do the alteplase, but that's definitely a misconception.
What's something about saline flushing that's not often discussed, but you wish people knew more about?
Maybe one little thing that I haven't mentioned, because most of that has been discussed, is that sometimes, and we know this as oncology nurses, our patients taste it when we flush. Now, we're thinking the whole time that's great because that means their catheters, whether it's peripheral or central, it's in a vein and they're tasting it. That means it's working and it's not infiltrating. However, it can be very uncomfortable for some patients. And so sometimes you'll be trying to do a pulsatile flush and the patient may think you're being kind of aggressive with it, or they may taste it and then not may not like that taste. So I like to encourage a patient, if they have that taste and it's very uncomfortable for them, to either chew some mint gum or suck on a mint when they come, bring them with them. An Altoid or something can be very helpful. And then if they just are concerned about how you're handling that flush, because it does look more aggressive, just teach back with the patient about how important it is that we do this. And I like to talk about the kitchen sink and how we have to keep our sink clean or it'll get clogged up, and we have to take care of our pipes in our house so that they don't get clogged up. And it's the same way with someone's central line. We've got to take care of it. And that studies show using some turbulence and some pulsation will keep your catheter from getting clogged up. And clogged up catheters lead to warm, moist environments with the clots and the fibrin for bacteria to grow and can lead to infection. So that's really important to teach our patients.
What additional training or education do oncology nurses need to implement saline flushing?
I think that I covered that, but just teach them the evidence, teach them how to flush, teach them the frequency with which they are to flush, teach them the science behind all this, and teach them about the harms of heparin, because when they realize that they could be giving something more benign that will not potentially harm the patient, it really helps.
And lastly, what would you recommend as additional resources for patients who want to learn more?
We developed in my organization patient teaching materials, and we developed a teach back because we knew that patients would be scared, obviously, when we told them we're no longer going to give you that heparin, and they would be worried about their catheter. And some patients were just open arms. Oh, great. Thank you so much. Let's get rid of that stuff. I didn't like that anyway. And now I don't have to pay for it. And other patients are very skeptical. So you have to have good patient materials, teaching materials, and good teach back method, or a scripting, if you will, for your nurses when you do the rollout so that your patients all hear it the same way. And providers, honestly, I think nurses are most expert in the maintenance and care of central line catheters more than our oncology providers. And many of them, I noticed when I would do my teaching, they didn't really even know what we were caring for the catheters with. It was just built into the order sets and they weren't really paying attention. So going back and teaching them why we did it this way forever, what the new evidence shows, and why we're moving to saline. And I really had a lot of support among the providers because they realized the risks and they were happy to not have those risks in their patients anymore. And some providers were actually surprised at the amount of heparin their patients were getting in their catheters.
Excellent. Well, again, MiKaela, thank you so much for being with us and just the importance of this topic for our listeners. Like I said, they're probably going to be going back and listening to this to remind themselves of the evidence, where to find that evidence, and how they can make some positive changes for their patients going forward. Do you have any final comments for us?
I think my only final comment is remember that lots of pulsation, frequent flushing, you're still going to have patients that get occluded, changes in intrathoracic pressure like coughing, nausea, vomiting. These all cause reflux of blood into the catheter that can sit there and cause an occlusion. So occlusions will still happen, but you can minimize the risk of occlusions by doing the pulsation and the frequent flushing.
Thank you so much.
Thank you.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.